Hello everyone, welcome back to the channel. I am Dr. Abin Jose and I am doing DM Interventional Radiology at Grand Medical College. And in this video, we'll be talking about varicose veins, how to identify them, what are the symptoms, signs, and how do we treat them. So varicose veins are basically dilated and tortuous superficial veins, and they all occur due to venous valve incompetence. If you see here in this image, this is the vein, and these are the small valves, and this will only allow blood flow in one direction, that is away from the extremities towards the central part of the body. But in case of varicose veins, in venous diseases, these valves become faulty and they will allow a flow of blood in both the directions, and hence blood will be more found in the dependent areas. They'll be pulling of blood in the extremities, and hence these veins will accommodate this increased blood, and they will become dilated and tortuous like this. And this image also depicts the same thing. So when you come to the anatomy, basically there are two systems. There is a superficial system and then there is a deep system. And then there are these veins that connect between both, and they are known as perforators. So here you can see this is the deep system and this is the superficial system, and this is the perforator vein that is connecting the both. So ideally the blood should go from the periphery to the central part of the body. And the second thing is the blood should flow from the superficial system into the deep system, ideally. So when it comes to venous diseases, there will be damage of these valves, and because of that, the blood will pool in the superficial system itself, and it won't go into the deep system. And perforator veins, when they are having venous disease, these valves will be incompetent and the blood will again flow from the deep to the superficial, or the superficial will not empty into the deep. That is the main issue. So here you can see these two images are the superficial system. This is the SSV, that is a short saphenous vein. So this comes in the lateral aspect of the foot below the lateral malleolus. It goes back in the leg and it joins the popliteal vein, and this junction is known as the saphenopopliteal junction. This one is the great saphenous vein. So this starts in the foot medial part, and it will be anterior to the medial malleolus, and it goes in the medial aspect of the leg and thigh, and it will join into the SFV, and here it will form the saphenofemoral junction. So the incompetence of the junction also will cause varicose veins, and these valve issues also will cause varicose veins of the superficial system, and even the perforator incompetence can also cause issues. So there are multiple perforators located at many levels. So here you have the Cockett perforators, then you have the Dodd, and then you have the Hunterian perforators. When it comes to symptoms, basically it is heaviness, aching, swelling, night cramps, etc. When it comes to signs, you can see the legs. There are multiple dilated tortuous veins over here in the legs over here. There is a discoloration, skill discoloration, and bit of ankle edema. Here there is skin changes, along with that there is a venous ulcer. Here also there is venous ulcer, skin change, and these dilated superficial veins. Here there is component of eczema also, and also lipodermatosclerosis. Here again you can see varicose veins and a venous ulcer again. One of the main classifications of varicose vein is CEAP classification. C for clinical, E for etiology, A for anatomy, and P for pathophysiology. So in clinical, you have C0, that is no clinical signs. C1 is telangiectasia. Here you can see these are telangiectatic veins, reticular or spider veins. C2 is these prominent varicose veins. C3 is the moment you see edema. And C4 is skin changes over here. You can see skin darkening and these dark spots over here. So these are skin changes that comes under class 4. And class 5 is an ulcer, venous ulcer that has healed on its own. And the class 6 is a venous ulcer that is not healed and it is having an active ulceration. In etiology, you have congenital, you have primary and secondary. Secondary, it is usually due to DVT. So whenever DVT doesn't clear, so it can lead to damage of the valves of the deep veins. And due to pressure difference, the other valves will become incompetent, and again that will cause varicose veins. And in anatomy, superficial veins, that is varicose veins involving superficial veins, deep veins, perforator veins. So there is something called as also deep venous incompetence, where the valves of the deep system, that is CFV, SFV, and popliteal vein, are damaged and they will show incompetence. So here you will have reflux when you keep the probe in the CFV, SFV, and popliteal veins. And pathology, you have reflux, obstruction, or both. So when it comes to diagnostic workup, best is duplex ultrasound. That is a gold standard. Here you can see this is the common femoral vein, which is a deep vein. This is the great saphenous vein, which is a superficial vein. This is also superficial vein, that is superficial epigastric vein. So ideally the blood should flow from the superficial system into the deep system, whether you are in rest or during Valsalva or any time. So here, whenever there is a junctional incompetence, what happens is the junction, the valve over here doesn't work. So because of that, the blood will flow from the deep system into the superficial system, and that is what you call as a venous reflux or a valve incompetence, junction incompetence. So when here in this, we will ask them to do Valsalva. So during Valsalva, there is increase of pressure and the blood will flow from the CFV into the GSV, and that is known as reflux. Here in this image, you can see there are multiple tortuous, dilated, superficial varicose veins. When it comes to management, first definitely we'll try for conservative management. That is class 2 compression stockings. Here you can see it is a graded compression stockings, means the compression power is more in the lower part, that is a dependent part of the leg, and it decreases as it comes up. So this is a graduated compression. And another thing is you should go for leg elevation, and exercise and weight loss will also help, and avoid prolonged standing or sitting. So when the conservative management fails, we can go for minimally invasive measures, and that is done by an intervention radiologist. So we can go for endovenous thermal ablation, or you can go for glue. So here in this first image is the glue. So here what we do is the dilated vein, that is usually we prefer a long segment, that is for a GSV or an SSV. We will inject glue into it, and we will give compression on top of the vein, and both the walls of the vein will stick to each other, and that varicosity will not be seen anymore. So the first image is the glue, this is the gun, and this is how we inject the glue. The second one, this is a laser or a radiofrequency ablation. So there's a thermal ablation method. Here you will pass the catheter. So this catheter will go within the vein. This also requires a long segment disease. So here within the vein, we will pass the laser or RF, and then once it is ablated, this vein will automatically close. They will get thrombosed, and then they will get fibrosed, and they will become a thin cord, and that's how the varicosity will disappear. So this is the actual laser, this is the sheath, and there's a laser going to be passed into it, and that will go into the long segment diseased veins. So, but whenever the disease is not a long segment, when it's small, dilated, veins, dilated varicosities. So what we do is we put a scalp vein into it, and we will inject a sclerosant, and the sclerosant will be prepared by tesserae method. With that, we will inject through the scalp vein and into the varicosities, and that will sclerose these varicosities. And if none of these work, we can definitely go for surgical ligation and stripping of the GSV or the SSV. Thank you.